Good day to all. I'm SITI ZALEHA from UNIVERSITI Malaya. I will present on Malaysian Octogenarian with acute coronary syndrome, 10-year change in management and outcome. For more than 2 decades, cardiovascular disease has been the leading cause of mortality globally. Similar trend is seen in our country, where approximately 50 people die due to ischemic heart disease every single day. The majority were men, Bumiputra, specifically Malay, and those aged 41 years old and above. The Malaysian population continues to grow from 28 million people in 2008 to 32 million in 2017. The age group distribution has also changed. The life expectancy increases, with the number of those more than 75 years old continues to expand. Tun Mahathir is the best example of octogenarian. He had previous history of cardiovascular disease and 2 severe heart attacks at the age of 81 years old. He is now 96 years old, a living proof with optimum treatment and lifestyle. Octogenarian can still enjoy good quality of life. In this study, we aim to examine the 10-year change in ACS management and outcome for octogenarian patients in Malaysia. Specifically, changes in coronary intervention, in-hospital evidence pharmacotherapies, 1-year all-cause mortality between the year 2008 and 2017. For this purpose, we use data from National Cardiovascular Disease Registry or NCVD. NCVD is a comprehensive registry that collects data on patients with cardiovascular disease from numerous source data providers throughout the country. The study was approved by the Malaysian Research Ethics Committee (MREC), and the following are the exclusion criteria for this study. Groups were compared using chi-square test. Variation in receiving treatment were examined using binary logistic regression. We further examined the association between treatment and mortality using the Cox proportional hazard analysis, adjusted for gender, ethnicity, ACS stratum, risk factor, and comorbidities. The study examined changes between 2 time points, year 2008 and 2017, to reflect on what have happened within these years. The number of data source providers or hospitals have increased between the 2 time points, and there was an increased number of octogenarians who presented with ACS. There is a significant change in the presentation of ACS. In 2008, STEMI predominates, while in 2017, NSTEMI predominates. Gender distribution remained relatively similar between the 2 years, but there was an increase in the octogenarian age at presentation. The majority of admission or ACS in octogenarian for 2017 were of Chinese ethnicity. In this study, we analyzed each in-hospital treatment received by the patient. The results are as follows. The PCI rate was less than 10% in both studied years. The use of intravenous thrombolysis in STEMI patients showed reducing trend in year 2017. Less than 1% of octogenarians were intervened with CABG. The prescription of aspirin were almost at maximum level, with significant increase from year 2008. The use of DAPT has significantly increased by 24% in 2017, while use of anticoagulant significantly increases by nearly 20% in 2017. Statin prescription is also near maximal, with 90% of patients receiving statin in 2017. Interestingly, the use of renin-angiotensin system drug have showed decreasing trend. The trend for beta blocker is similar to ACE inhibitor ARB in both years. The prescription to octogenarian are less than 60%. There were no significant variation found for PCI, aspirin, DAPT, and statin when comparing across gender, ethnicity, ACS stratum, risk factor, and comorbidities. Those with NSTEMI and unstable angina were more likely to be prescribed with anticoagulant than STEMI, reflecting the guideline for this type of ACS. As for ACE inhibitor ARB, those with chronic lung disease patients were found to be significantly less likely to be prescribed with them. In beta blocker, octogenarian ACS patients with hypertension are less likely to be prescribed with it. In the 10-year time, the 1-year all-cause mortality has reduced by 7.4%, although not significant. For STEMI, risk for mortality was significantly increased with the use of ACE inhibitor and beta blocker. Similar trend is seen with NSTEMI patients. This octogenarian may already have congestive heart failure and CKD, which on its own carries poor prognosis. Although we have adjusted for CHF and CKD, we did not examine their clinical classification, presence of cardiogenic shock, and their creatinine level or dialysis status. As for unstable angina, the hazard ratio for any of the drug and treatment do not stand out. In conclusion, there was a change in the demographic of octogenarian presenting with ACS with later age of presentation and change in ethnicity distribution. The prescribing for aspirin, DAPT, statin, and anticoagulant have been high since 2008, with a major increase seen in DAPT prescribing. Lower risks were seen for ACE inhibitor ARB and beta blocker, which were found to be associated with higher 1-year all-cause mortality. This finding needs to be investigated further. Our analysis suggested that for octogenarians with acute coronary syndrome, there are much room for improvement in intervention, especially PCI, that can be explored further. And with that, I end my presentation. Thank you for your time and good day.